because I don't have my paperwork with me. Excuse me. As long as I'm being unconventional, I may as well be completely unconventional with a panel. So Kent, you get to be my star right now. You realize that? Even though we have all these other acclaimed professionals at your sides. Yes. Can you handle it? Thank you. We'll do our best. Okay, so Dr. Holtorf is a physician and MD and the medical director of the Holtorf Medical Group and the nationwide Holtorf Medical Group affiliate centers. He is the medical director of the nonprofit National Academy of Hypothyroidism. He's a fellowship lecturer for the ABAAM, the endocrinology expert for the AOL Health, and founding director of the nonprofit Bioidentical Hormone Initiative. Dr. Holtorf has published a number of peer-reviewed endocrine reviews, including on the safety and efficacy of bioidentical hormones, inaccuracies of standard thyroid testing, testosterone replacement for men and women, the diagnosis and treatment of growth hormone deficiency, and on the diagnosis and treatment of HPA axis dysfunction in chronic fatigue syndrome and fibromyalgia. He is also a reviewer for the Journal of Endocrine, Postgraduate Medicine, and Pharmacy Practice. All right, so let's go on to our panel. Let's get with the questions. Let's see. There's a question that we haven't addressed too often. Sustained release naltrexone. Will it work like conventional naltrexone? Why or why not? I think I'd like to address this to Stephen Dickson. Kent, if you could bring that microphone over to Mr. Dickson, please.
We were just talking about this at the break, actually. I mean, I think you look at the pathways involved. If you're looking at the blockages of the endorphin pathway and the original theory of how it works, then sustained LDN is not going to work. The reason behind this, I think, is probably coming from a colleague over there. No, not from yourself? Okay. Well, I was talking to somebody who's making an injection, potentially, that would give a sustained release of like 1.5 milligram a day. So my personal feeling is it would have to be, I think for some of the diseases, like the psychiatric diseases that we're talking about, some of the patients that you're talking about where you're taking it twice a day, an injection might be helpful, that would give a sustained release. But for the rest of the autoimmune diseases, probably I would find it doubtful. So.
Okay, thank you, Stephen. Ken, we've been saving this since this morning for you. On thyroid, my wife has Graves' disease. Her thyroid was ablated 20 years ago, but she still suffers from Graves' syndrome. She has been taking LDN for nearly a year at 4.5 milligrams daily, but sees no improvement in her symptoms. What do you recommend? Does one have to have a functioning thyroid in order for LDN to prove beneficial?
We actually see a lot of Graves' patients have had their thyroid ablated, and then basically they get treated with just T4. And I don't know what she means by Graves' syndrome, but
Graves' disease.
Yeah, which is hyperthyroidism. Maybe she's talking about the eyes to basically, the antibodies to Graves cross-react the ones that are attacking the thyroid to the back of the eye. So that's semi-permanent. We do get some relief. Low-dose naltrexone is a key treatment to lower those antibodies, but also she needs T3 along with her likely taking T4, because usually the thyroid secretes some T3, and people go on, basically once they get their thyroid ablated, even if they're normal, let's say for cancer, average weight gain is about 27 pounds. So when they say, oh, we're just going to take your thyroid out and replace it with Synthroid, average weight gain 27 pounds. So it's basically suboptimal replacement.
Okay, so it's suboptimal
thyroid replacement. Yeah, I'm not sure about, when you say Graves' syndrome, because I don't think she's still hyper.
Okay. Does LDN increase suicidal thoughts in depressed patients taking antidepressants? Is that something, Dr. Ulrich, do you feel comfortable with that?
Sure.
Or Dr. Lanius?
Usually low-dose naltrexone will improve mood. There are some exceptions, and usually that's the case when there's a severe dissociative disorder where your dose is too high and you start breaking into amnestic material and parts of the self that kind of hold that suicidal ideation, and essentially the solution to the problem is backing off the dose as quickly as you can.
Okay. What about LDN in Huntington's disease? Dr. Crowley, No?
No, I have not used it. No.
Not used it? So no one has experience with Huntington's and LDN. We'll save that for the next panel, perhaps. Is LDN effective treatment for psoriasis, and if so, what dosage? Dr. Crowley, is that something you'd like to address?
Yeah, it can be very good in severe psoriasis, yeah. And I think in England they've been using it quite a bit, and I know that they're responding positively to it. That it's been now I've treated maybe 10 cases of it, but yeah, I noticed that in severe psoriasis it will help. That's my experience.
I just want to add one little thing with psoriasis that ozonated oil, basically rub it on, works really well.
Okay. This is a general question for the panel, but especially Dr. Crowley. So you may as well pull a mic over there, Patrick. Are there any contraindications or synergistic enhancement of LDN and oxidative therapies, such as IVC, ozonating blood with LDN in multiple sclerosis patients?
Well, I personally don't have any experience with that. No, I mean.
You know, people think you know everything, Pat.
Just the LDN, that's what I know. And then in relation to LDN, of course, I'm on multiple sclerosis. I'm extremely positive about it. And I wish everybody who has MS was put on it. But other therapies associated with it, I'm not personally familiar with.
Kent, I know you work with a lot of alternative and integrative approaches.
Yeah, we actually use a lot of ozone and other oxidative therapies for autoimmune diseases, MS, and of course, chronic infections. And almost always there's a chronic infection that's driving the autoimmune disease. So the key is, I should have mentioned this in the Graves case as well, that I need to look for an underlying infection. And when the studies are just overwhelming and looking at, 90% of people will have a chronic infection. So that's what needs to be investigated.
Okay. I think we'll direct this towards Stephen, if you feel up to it. Okay. Grab a microphone, please. Can LDN be used in conjunction with Rebif, interferon beta 1A? We've sort of discussed that those things may decrease the effectiveness of LDN, but if someone doesn't want to walk away from the Rebif, can they use it in conjunction with LDN?
But the pathways are theoretically completely different, so there would be no. The pathways are completely different theoretically, so there would be no real reason why you would say it was contraindicated. In fact, there's a great number of patients who we see through in the UK who are already on the likes of Rebif, and then they start LDN as well. And sometimes they come off with the Rebif, and we don't see any real clinical problems. So I know that there'll be differing viewpoints on this in the room, that you must do one or the other. But if you're stable on Rebif and you want to try LDN, most of the clinicians that we deal with will allow you to do so, and we haven't seen any major problems with that.
Thank you. Dr. Chopra, with LDN, my neuropathic pain has decreased from a 9 to a 7 over 6 months. I have OIH, fibromyalgia, ligament laxity, and my CIDP, chronic inflammatory demyelinating polyneuropathy, is in remission after IVIG. My IC and IBS seem to be cured. Can I expect it to decrease any more? And if not, which is better to supplement with, ketamine or lidocaine infusions? My pain clinic wants me to go to the Mayo Clinic rehab because they feel my improvement is finalized and want to stop LDN, and they refused me ketamine, saying they don't have the science to justify it for pain. But my psychiatrist suggested trying ketamine and possibly use it intranasally along with LDN. Any suggestions, Dr. Chopra? That's a lot of question.
I know. Did she say she has CRPS or RSD?
She did not mention either of those. She said OIH, fibromyalgia, neuropathic pain, ligament laxity, chronic inflammatory demyelinating polyneuropathy.
I see.
That's the list.
I don't think an IV ketamine would be justified in this. The fact that she has neuropathic pain, that's kind of a CRPS. It's worth trying it. You can definitely try nasal ketamine. It'll give you a short-term breakthrough pain relief. But I would continue with the LDN. She seems to be doing fine.
Okay. Is Dr. O'Brien in the room? Dr. O'Brien?
I just want to mention on that patient
Yes.
there, I mean, that's a typical Lyme patient, and that patient really needs to look at underlying infectious condition. But we use a lot of ketamine along with low-dose naltrexone. Use it orally. It's very opioid sparing, so it allows you to use the LDN. IV ketamine we use for depression, but also for chronic pain syndromes like that as well. And it's nice because they can get off their opiates oftentimes.
Can LDN help a patient who has pain from a synovial cyst, which formed 2 years after having a laminectomy, to alleviate nerve compression from spinal stenosis? Do you want to deal with that, Dr. Chopra?
No, it won't. If the nerve is being compressed with a synovial cyst, the best option is to actually, they can do it percutaneously, they rupture the synovial cyst or surgically remove it. But she has to be sure, or the patient has to be sure that this is the reason for the pain. Just because she has a synovial cyst doesn't mean that may be the reason for the pain. There could be other reasons too.
All right. I have 2 in a row here, which are directed to Dr. O'Brien. Paul, would you like to actually pop up here, please, and we'll come back to these questions. Mr. Cox or Dr. Lanius? I'd be happy to. So is Lanius up here? Oh, there you are. Good, good. Case study. A driver and passenger dog are involved in a serious car accident. The veterinarian treats the dog's injuries and also administers pain medications. He explains that the dog experiences pain but doesn't worry about it, as in no emotional connection. The driver develops PTSD with panic attacks when seeing a crash site. The dog happily jumps back into the car. What possible advantage does a primate have with a different limbic system? If during... I'm sorry, it's not funny. Stop that laughing. I'll mimic you. I'll parrot you back. If during or immediately post-crash, the driver attempts to disassociate emotions with the event, can PTSD be avoided? Can the driver try to react like the dog did? First off, whoever did this, thank you for printing. Do you want to try that one?
I'd probably pass on that.
Thank you. And I'm sure Lanius is not back. Oh, my goodness. So, good. All right. Let's split out. Go back to our seats, maybe, and we'll leave you here. Sorry, you have to have the A seats while Dr. Holtorf speaks. Unless you don't want to be up in front, Pradeep. Click up and down, meaning the page up, page down? Yeah. Okay.
Who knows?
Beautiful. Lovely. All right. So keep those questions coming. We'll be getting more questions after Dr. Holtorf gives his presentation. Those who are live streaming, please send as many questions as you might have on your minds. Those in the audience, thank you for these very detailed questions. I'm fascinated.